Greetings to Madam Rosia and my fellow colleagues. Today, Group 9 will be presenting to you about myocardial infarction. Here are the things that we are going to present to you in this video. So first, let's look into the definition of myocardial infarction. Myocardial infarction, according to Franco Giannis in 2011, can be defined as a sudden ischemic death of myocardial tissue due to a thrombotic occlusion of a coronary vessel caused by a rupture of a vulnerable plaque. Next, we look into the risk factors of myocardial infarction. The first non-modifiable risk factors of myocardial infarction would be increasing age. This is due to older adults are more likely to die of a heart disease compared to younger people. Next is sex, where men tend to have heart attacks earlier in life than women. Next is family history of premature coronary heart disease and also genetic factors. Next is the modifiable risk factors of myocardial infarction. The first one would be smoking, sedentary lifestyle, hypertension, diabetes mellitus, and also obesity or BMI more than the normal range.
So, for the pathophysiology, in the clinical context, myocardial infarction is usually due to thrombotic occlusion of a coronary vessel caused by the rupture of a vulnerable plaque. The acute occlusion of one or multiple large epicardial coronary arteries for more than 20 to 40 minutes can lead to acute myocardial infarction. The occlusion leads to a lack of oxygen in the myocardium, which results in sarcolemmal destruction and myofibril relaxation. Also, an embolus can travel to the heart and get lodged in the coronary artery, which may prevent oxygen-rich blood from flowing to the areas of the heart that the blood vessel supplies. Cardiac cells have a very large oxygen demand. A decrease in oxygen-rich blood flowing to the heart can cause ischemia. If not aggressively treated and reversed, it only takes 20 minutes for tissue necrosis and cellular death to occur.
Now, we are looking into the signs and symptoms of myocardial infarction. The first one would be shortness of breath. The second one would be sudden chest pain. Next is nausea and vomiting, diaphoresis, and lastly, palpitations.
During an emergency situation, once the individual is suspected to have signs and symptoms of myocardial infarction, the healthcare personnel may provide a few early interventions before the patient being admitted to the hospital. For example, oxygen therapy of 2 liters per minute may be given via nasal prong and continuous ECG monitoring will be done. The patient also will be given pain management using nitrate and aspirin before they are being triaged to the appropriate center. Once they are admitted, their drug therapy and the timing of the revascularization will be given depending on their clinical pictures and diagnosis. There are few drug treatments that can be given to MI patients. For example, antiplatelet agent and anticoagulant agent will be given to the patient with myocardial infarction to embolize the blood clot. Anti-anginal therapy, commonly nitroglycerin, also can be given to reduce their angina. For patients who has done percutaneous coronary inflation, glycoprotein 11B or 11A inhibitor will be given to prevent thrombosis during PCI intervention. Another drugs such as beta blocker, ACE inhibitor, and statin also may be given to MI patient. Reperfusion therapy is a common medical management for MI patient. For ST elevation myocardial infarction cases, an immediate percutaneous coronary intervention where the daughter balloon inflation is less than 90 minutes, or immediate reperfusion of fibrinolytics such as atiplase in the first few minutes to hours after onset of MI, where door-to-needle time is 30 to 60 minutes will be given. If there is slightly delay in the availability of PCI, thrombolysis will be given to the patient with STEMI. For non-STEMI, The unstable non-STEMI patient will be proceeded directly to an urgent angiography to identify coronary lesion requiring PCI or coronary artery bypass graft surgery (CABG). Immediate reperfusion may not be urgent for uncomplicated non-STEMI patients. Hence, angiography typically will be done 24 to 48 hours of hospitalization to determine the patient for PCI or CABG. Finally, for post-discharge rehabilitation or medical management for MI attack patients, they are advised to manage their reversible risk factor of myocardial infarction attack such as hypertension, diabetes, diet, sedentary lifestyle, obesity or smoking cessation. They are also will continue their treatment such as antiplatelet drugs, beta blockers, ACE inhibitors or statin. Functional evaluation of MI also will be done to the patient to monitor the management of their disease to prevent from reoccurrence.
Next, we will go to the nursing intervention. For nursing diagnosis that can be diagnosed for a patient who are having myocardial infarction are pain related to ischemic myocardial tissue, activity intolerance related to imbalanced myocardial oxygen supply and demand, risk for decreased cardiac output, and risk for ineffective tissue perfusion. Nursing intervention for the pain related to ischemic myocardial tissue are nurses should monitor and assess the characteristic of patient's pain, noting verbal reports and non-verbal cues such as moaning, crying, grimacing, restlessness, and clutching of the chest. The rationale of this intervention is to act as a baseline data. For the next nursing intervention are provide a quiet environment and calm activities and place the client in a position of comfort. The rationale of the intervention is to decrease the patient's chest pain or dyspnea. Next is administer supplemental oxygen by means of a nasal cannula or face mask as prescribed by the doctor. The rationale of this intervention is to improve the oxygenation of the myocardium and other tissues. Next is administer medication as prescribed by the doctor such as morphine. The rationale of this intervention is as morphine are given to relieve the patient's pain.
Next, nursing intervention for activity intolerance related to imbalanced myocardial oxygen supply and demand. The first nursing intervention is assess and monitor the patient's vital signs, including blood pressure, heart rate, and SpO2 before and after the activity to check for the cardiopulmonary status of the patient. The SpO2 of the patient must be monitored closely to determine the need of supplemental oxygen when performing activities. Second, encourage patient to limit the activities by resting in the bed more often to reduce oxygen consumption, thus reducing the cardiac load. Third, teach patient to do range of motion exercise while at the bed to enhance blood circulation and to prevent the declining of muscle, and advise the patient to gradually do active RAM by start with standing and walking for 1 to 2 minutes and sitting again. Fourth, encourage patient to do the relaxation techniques or the diversional therapy such as listening to the calm music to reduce stress, thus reducing the anxiety of the patient. These relaxation techniques or diversional therapy will help patients in improving the coping skill of the patient towards stress and anxiety. Fifth, provide the patients calm and comfortable environment by limiting the visitors and controlling the noise in the ward.
Next is the mechanical complications. Peak incidence is usually between 3 and 7 days following MI when the myocardial tissue is softest and most vulnerable to rupture. One of the mechanical complications that will occur from myocardial infarction is acute mitral regurgitation. Acute MR can result from the rupture of a left ventricular papillary muscle, resulting in a flail mitral leaflet, usually the posterior leaflet. This causes an abrupt decrease in cardiac output, resulting in congestive heart failure and in some cases cardiogenic shock. Moreover, cardiogenic shock may occur when there is significant reduction in the cardiac output, resulting hypotension, decreased organ perfusion, and elevated left ventricular filling pressure, which may result in congestive heart failure. Next is the ventricular septal rupture. So, an acute ventricular septal rupture can occur several days after an acute infarction due to softening of the necrotic portion of the septum. This can happen in both infero-posterior and anterior myocardial infarctions. Next is pericarditis. Because of an inflammatory exudate in the pericardium, post-infarction pericarditis usually begins several days after the infarctions. Because of its pleuritic nature, radiation to the left trapezius ridge and associated low-grade fever and pericardial friction rub, pericarditis pain are differs from infarct pain.